Alright guys, we'll start. Alright? The others can come in a little later. Alright, so the topic today is anti-Mullerian hormone AMH and its significance. Is everybody listening?
Yes, ma'am.
Yeah. Alright, so the first slide is an introduction. So I'd like, usually we ask the question, what is AMH? So AMH, or anti-Mullerian hormone, is a substance produced by the granulosa cells in the ovary and is a test to measure ovarian reserves only. It is first made in primary follicles that advance from the primordial follicle stage. At these stages, follicles are microscopic and cannot be seen by ultrasound. AMH production is highest in preantral and small antral stages, less than 4 millimeters in diameter, so you can see how small it is of development. Production decreases and then stops as follicle grows. There is almost no AMH made in follicles over 8 millimeters. Keep that in mind. Therefore, the levels are fairly constant and the AMH test can be done on any day of the woman's cycle. So you don't have to wait like the other tests that we do, alright? So here we go. So you've got the fertility of health, you've got the egg number, you've got egg quality, currently measured by chronological age, you've got genetics involved, and you've got the reproductive organs. So the serum levels, relative levels are, you've got the fetal, the childbirth, and the puberty. And you can see the cross section of the egg. And below you've got, all this is dependent on the follicle stimulating hormone in the lady. So you've got the anti-Mullerian hormone starting from the most primordial, small preantral, large antral, then you've got the antral 2 to 7 millimeters, and then you've got the bigger ones. And you've got the effect of FSH and then inulin B. So here we go, you've got the sex differentiation by potential gonad, female duct Mullerian, male duct Wolffian. You can see the difference at this stage. Then you've got the urogenital sinus, and then you've got the separation. You've got the oviduct, you've got the ovaries, the bladder, the uterus, the cervix and vagina. And in the male, you've got the testes, you've got the epididymis, you've got the bladder, and you've got the seminal vesicles and the prostate. So that's when the differentiation takes place. An interesting fact we tend to forget: before sexual differentiation, all fetuses possess two structures where the internal sex organs will be called the Mullerian and Wolffian structures. This is what we saw in the previous slide. Testes produce a substance called anti-Mullerian hormone AMH, which causes the Mullerian structures to regress. Has to be, right? The testosterone produced by the testes causes the Wolffian structure to develop into male internal structures. How beautiful. Lack of testosterone prevents the Wolffian structures from developing and causes it to regress, and lack of AMH allows the Mullerian structures to develop into female parts. So this was the differentiation from the previous slide. So at the beginning of each menstrual cycle, 5 to 7 primary follicles begin to develop from a pool of primordial follicles in the woman's ovaries. This growth is caused by the rising levels of FSH in the blood. These follicles compete with each other for dominance, as only one will develop fully and release a mature egg from the ovary. AMH is produced by cells surrounding these growing follicles. Every woman is born with all her eggs, albeit immature, already in her ovaries. Keep that in mind. So that's the storage. These eggs are created earlier on during fetal development, weeks 18 to 22 post-conception. However, after creation, the development is halted such that they become suspended at an immature stage during the delicate stage of cell division. So the child is born with a certain amount of egg load. Further, these immature eggs only become active again once a woman reaches puberty, at which point one will mature and be released each month in response to the rising levels of SHH, and that is what happens at the time of period. Some few eggs will remain in this dormant immature state for up to 50 years until menopause. Every woman is born with a different ovarian reserve, and the rate of decline of the primordial follicle pool throughout her reproductive life will also vary. Research indicates women can be born with between 35,000 to 2.5 million primordial follicles per ovary. This is from according to Wallace and Kelsey. With only an average of 450 ovulatory monthly cycles in a typical female reproductive lifespan, the majority of follicles will degenerate over time. So can you see from so many what they come down to eventually? So AMH is secreted by pre-antral and antral follicles. So you've got the initial recruitment with the effect of AMH, and then you've got the FSH, and you can see the sizes how they vary, going up to I think 8 to 12 millimeters, and then develops into a pre-ovulatory follicle. So ovarian reserve tests, that is what AMH is. The practice committee of the American Society of Reproductive Medicine, fertility, sterility, that's the 98, that's the issue numbers. So this is what do we do then? What do you do then? To identify patients at risk of having diminished ovarian reserve, to add prognostic information to the counseling and planning process for infertile couples seeking treatment. So this is something to do with couples who are trying to conceive and have not been very successful. How are they used? To counsel patients regarding duration of their reproductive lifespan, to predict the likelihood of success with assisted conception, to assess the detrimental effect of lifestyle choices and medical treatment on reproductive health, to guide the selection of appropriate treatment pathway. What are the measures of ovarian reserve? Biochemical measures of ovarian reserve that reflect the biology of the aging ovary. Ultrasound imaging techniques for visualization of the ovaries. So yeah, this usually deals with the woman who's trying to conceive and has not been very successful, depending on her age. So all these measures are taken to see whether she can go in for IVF and successful conception can be done that way if she has the required egg load. AMH would be ideal biomarker for ovarian reserve, we ask the question. Readily accessible and cost effective, simple to use and non-invasive, precise and reliable, diagnostic utility is there, add value to tests already available, easy incorporation into routine clinical practice, quick results to increase efficiency of testing, minimum patient discomfort, reproducible with low variability between users, minimized between user and between lab variability, ability to detect values in a wider measuring range, including negligible, poor, normal, and high value related to ovarian reserve, increased confidence in clinical decision making based on quality of results. So all this is between the gynecologist as well as what your sonologist tells the doctor and the treatment. I think we lost one. Go back. Yes, okay, further, sorry. What are the advantages of measuring AMH, we ask? The advantage of measuring AMH is that throughout a menstrual cycle, AMH levels remain consistent rather. This makes AMH a more reliable test, not constrained to measurement of specific days of the menstrual cycle like FSH and progesterone. The AMH test is useful in assessing conditions such as polycystic ovary syndrome and premature ovarian failure. A decrease in AMH signifying approaching menopause can be seen 5 years before a difference can be detected in the levels of FSH and inhibin B. In clinical practice, AMH measurements may be useful in the prediction of poor response to fertility medicine and cycle cancellation. It can also indicate a potential for hyperresponse and ovarian hyperstimulation syndrome. Note, AMH normal range will change depending on age. 1 mg per ml equal to 7.14 picomoles. Both units used in reference ranges. Okay. As a measure of ovarian reserve, AMH has the following key advantages. It does not require experienced personnel or ultrasound equipment, which may facilitate incorporation into routine practice. Can be measured on any day of the menstrual cycle. Low intercycle and inter-individual variability. Less operator variability compared with AFC. Strong correlation with ovarian reserve and the remaining primordial follicles pool. Able to distinguish between negligible, poor, normal, and high values related to ovarian reserve. Provides confidence in the use of ovarian reserve assessment to facilitate patient-tailored management. So it's got a lot of advantages. And these are the values. You've got the optimal fertility, satisfactory fertility, low fertility, very low undetectable, higher levels that can be associated with PCOS. So you can see how the values change from a normal of 4 to 6.8 Hg, coming down to 22 to 4.3 to 2.2, 0 to 0.3, and less than 6.8. Okay, keep this in mind depending on what sort of parameters you are using in your assay. So good agreement between Lexis AMH results and AFC subgroups. Of course, this is a Roche assay, so the comparison is there. So you got poor AMH less than 0.681, normal is 0.681 to 2.27, and a high is more than 2.27. So you've got the poor, the normal, and the high ranges. Okay. No, go back. So in multi-center evaluation, 3 AFC groups, that anterior follicular groups, were defined based on 2 cutoffs, 7 and 15, corresponding to poor, normal, or high values. Corresponding AMH groups were calculated and percentage of agreement in the table. The data is there. These data might be useful for clinics using both AMH and AFC to help translate from one marker to the other. Given the variability of AFC, each, each site should review these figures for transferability to their own specific conditions. Okay? So 8 specific AMH reference values. So here you can see ages from 20 to 24 and the values the normal, and you can see the difference 25 to 29, 30 to 34, 35 to 39, 40 to 44, 45 to 50. 5-year gaps between the ages, and you can see the variation of the values. Take a look at it. All right. So distribution of AMH values to the single year age groups 27, 32 to 35, 40 years old demonstrates with advancing age increasingly skewed distribution of AMH values. So as the age increases, the values are not very exactly skewed. Okay. So AMH and fertility. Since AMH is produced only in small ovarian follicles, blood levels of this substance have been used to attempt to measure the size of the pool of growing follicles in women. Research shows that the size of the pool of growing follicles is heavily influenced by the size of the pool of remaining primordial follicles, microscopic follicles in deep sleep. Therefore, AMH blood levels are thought to reflect the size of the remaining egg supply or ovarian reserves. Interesting. Okay. Further, with the increasing female age, the size of the pool of remaining microscopic follicles decreases. Likewise, the blood AMH levels and the number of ovarian antral follicles visible on ultrasound also decreases. Women with many small follicles, such as those with polycystic ovaries, have high AMH hormone levels, and values that have few remaining follicles and those that are close to menopause have low anti-Mullerian hormone levels. Okay. So, antral follicle count, your AFC, is strongly correlated to the number of remaining primordial follicles. How is it measured? AMC is determined by counting the number of antral follicles 2 to 10 millimeters in diameter in both ovaries using 2D and 3D ultrasound imaging techniques. There is variation between clinics on recommended size of an antral follicle, example 2 to 5 millimeters or 2 to 10 millimeters raised to cube. When is it measured? It is recommended that AFC should be measured during the early follicular stage of the menstrual cycle, days 2 to 4, to minimize the effect of intra-cycle fluctuation. Okay, here we go. Follicles indicate by white arrows. You can see them. It's an ultrasound picture. Okay. Next one. So AMH levels and pregnancy chances with in vitro fertilization. So this is what we come to eventually. Women with higher AMH values will tend to have better response to ovarian stimulation for IVF and have more eggs retrieved. In general, having more eggs with IVF gives a highest chance of successful rate, isn't it? AMH levels probably do not tell us much about egg quality, but having more eggs at the IVF egg retrieval gives us more to work with. So we are more likely to have at least one high quality embryo available to transfer back to the uterus. This is how it works. Dr. Gurmeet Sharma, Chicago, has done research for using AMH levels to predictive IVF outcome. His research showed high AMH levels correlate with low cancellation rates, retrieval of more eggs, higher live birth rates, and high chance of freezing of leftover embryos. Low AMH levels alone do not predict low IVF success in women under 35. So the age also is important. So here you have the antral follicle counts, less than 4, 4 to 6, and so on. Interpretation, very low, less than 4 is very low, 4 to 6 is low, 7 to 10 is reduced, 11 to 30 is normal, more than 30 above normal, could be PCOS. Expected response to FSH, the first one is very poor, less than 4, then you got poor, you got reduced, between 11 and 13 is good, more than 30 is increased risk of hyperstimulation. Then you got anticipated cancellation of IVS. So less than 4, very high, 4 to 6 high, 7 to 10 increased, 11 to 30 low, more than 30 low. Then anticipated pregnancy rate with IVF, the first one is very low, 4 to 6 is low, 7 to 10 is decreased, 11 to 30 is excellent, more than 30 is good. Okay. So all depends on the AFC. Dr. Sherban has done research on using AMH levels to predict IVF outcome. His research showed high AMH levels correlate with low cancellation rates, retrieval of more eggs, high live birth rates, and high chance of freezing of leftover embryos. Low AMH levels alone do not predict low IVF success rate in women under 35. Couples should not be excluded from attempting IVF due to low AMH values alone because live birth success rates were reasonable in these cases. So here you have a family, happy family, and here they're also showing how the sperms move towards fertilizing the embryo. Okay. So AMH is very useful for assessment of menopausal status, including premature ovarian failure, assessing ovarian status, including ovarian reserve and ovarian responsiveness, as part of an evaluation for fertility and assisted reproduction protocols such as in vitro fertilization. Assessing ovarian function in patients with polycystic ovarian syndrome. Evaluation of infants with ambiguous genitalia and other intersex conditions, so this is sad. Evaluating testicular function in infants and children. Monitoring patients with anti-Mullerian hormone secreting ovarian granulosa cell tumors. Interpretation provides information to assist in interpretation of the test results. Menopausal women or women with premature ovarian failure of any cause, including after cancer chemotherapy, have very low anti-Mullerian hormone, often below the current assay detection limit of 0.1 mg. While the optimum AMH concentrations for predicting response to in vitro fertilization are still being established, it is accepted that AMH concentrations in the perimenopausal women to menopausal range indicates minimal to absent ovarian reserve. Depending on patient's age, ovarian stimulation is likely to fail. In such patients, by contrast, if serum AMH concentration exceeds 3 mg, hyperresponse to ovarian stimulation may result. For these patients, a minimum stimulation may be recommended, depending on the results. Okay. Continued, in patients with polycystic ovarian syndrome, AMH concentrations may be 2 to 5-fold higher than age-appropriate reference ranges. Such high levels predict anaerobic and irregular cycles. which is the case of people with polycystic ovary syndrome. In children with intersex conditions, an AMH result above the normal female range is predictive of presence of testicular tissue, while an undetectable value suggests its absence. In boys with cryptorchism, a measurable AMH concentration is predictive of undescended testes, while an undetected value is highly suggestive of anochria or functional failure of the abnormality cited gonad. Granulosa cells, tumors of the ovary may secrete AMH, inhibin A, and inhibin B. Elevated levels of any of these markers can indicate the presence of such a neoplasm in women with an ovarian mass. Levels should fall with successful treatment. Rising levels indicate tumor recurrence and or progression. Caution: AMH has to be substantiated with other tests besides patient history. Like all laboratory tests, anti-Mullerian hormone measurement alone is seldom sufficient for diagnosis, and results should be interpreted in the light of clinical findings and other relevant tests such as ovarian ultrasonography, antral follicle count for fertility evaluation, abdominal or testicular ultrasound, intersex or testicular function applications, and measurement of sex steroid, estriol, diol, testosterone and progesterone, follicle stimulating hormone, FSH, inhibin B for fertility, and inhibin A and B for tumor workup, depending on days of menstrual cycle, usually day 3. Elevated AMH is not specific for malignancy, and the assay should not be used exclusively to diagnose and exclude an AMH secreting ovarian tumor. So it has many interpretations, and I think that's game. Interesting or troublesome? Guys? Hello? Everybody's gone to sleep?
No, ma'am. It's very good, ma'am. Yeah, something new for us
Yeah,
to learn.
it's you have to understand this.
Yes, ma'am.
You have to understand this,
We
especially.
have to read it once again, yeah.
No. Also, like I said, if you are working in the lab, you must know what is the AMH, what is the interpretation. And sometimes close relationship working with the gynec and the sono gives a lot of results. And it's interesting. The sonography results are interesting. Nazreen, what do you think?
Yes, ma'am, because low AMH level does not mean that you cannot get pregnant.
Correct.
It just means that window might be smaller, but you may not respond to the as strongly to fertility treatment.
Yeah,
That's
usually
why
it is
ultrasound
used.
is-
One case is you are. I wish I could have. Let me see if I can get Sheely on for a couple of these. She can do a presentation because she works with IVF, and definitely this is a tool for to push the patient towards IVF if needed, if she cannot conceive naturally.
And the reference ranges are also the specific age range reference ranges.
Yes.
So it can help you to understand the specific tests that you are doing. It is a slight kind of a challenge also for interpretation.
It becomes important in women with PCOS. That for them it's important.
Normally we ask for the history also to the patient for fertility, IVF for prediction, that PCOS, diagnostics and all. If they have a history, then it is easy to release the report.
True.
Because it values normal optimum 1.0 to 3.0 is also challenging, and low values are also challenging. And it's a problem. So we have to go by the history.
That is there, and also depends how skillful your gynec is. Gynec help is very, very, very important. I feel Because over the years I'm dealing with all sorts of people, especially gynacs, who are very dynamic. And they can help to conceive with a little bit of counseling. And of course now these tests have come through. When I started practice early in India in the 70s, America was also not that advanced with all these tips. And I find that a good gynac can help and does help.
Yeah, I'm happy with the gynecologist over here and I'm happy with the pathologist over here, but I'm not happy with the GPs over here.
With the what?
Normal doctors, there
Yeah.
are
Okay, GP.